Hi, my name is Vidya, and I'm a specialist registrar in transplant surgery and a PhD candidate in health informatics. I'm currently based at the University of Manchester in the United Kingdom. I'm pleased to present our paper titled Kidney Cloud, a clinically co-designed solution to support kidney services with assessing patients for transplantation. This paper is part of the wider Kidney Cloud project, which aims to better understand data journeys and clinical pathways in kidney transplantation with a view to inform meaningful digital transformation. Transplantation is a complex clinical service, usually delivered out of central transplant centers, which receive patients from multiple renal referral units. Transplantation is the ideal treatment for patients with kidney failure, as it provides an increased longevity of life, as well as improved quality of life measures. However, patients are often referred across specialty and organizational boundaries along the clinical pathway, and therefore managing clinical data in transplantation is an administratively challenging task. Current EPRs are unable to support this need, and thus there is a dependence on manual processes to organize, communicate, and store clinical data in transplantation. The aim of this project was to better understand the clinical pathway and indeed how data moves along the clinical pathway when patients are transferred between organizations and clinical areas. And this paper in particular will report on the early prototyping and the iterative co-design of a clinical interface that meets the needs and requirements of this multi-center workflow. The methodology is broken down into several components. We first used a swim lane analysis using customer journey modeling language to ascertain in detail the clinical pathway, including the actors, the touch points, as well as the communication pathways between these various actors. We then undertook repeated cycles of requirements gathering using domain experts within the Department of Renal Transplantation at the Manchester University NHS Foundation Trust. And with their feedback, we developed a user interface incrementally using Adobe. I myself acted as a clinical super user and was able to communicate across disciplines and liaise with the designer to better describe the clinical requirements. We ensured that we adhered to established guidelines from an accessibility perspective and also from a design perspective. This diagram summarizes the design process, and I hope that this is a useful methodology for other health information technology developments. Results of the swim lane analysis identified that there were several channels of communication at present. Patients had significant over 50 number of clinical touch points along the pathway. Currently, there were 5 different IT systems in use, and this does not include the shared drive that the department implemented to manage transplant records. We found there were several clinical team members that were involved and a total of 5 healthcare organizations as part of the clinical pathway. User research meetings revealed that a significant ask from a improved system would be auto-population of data fields, as currently there was a full onus on manual population of clinical data as part of the patient pathway. Staff reported that it was important for the user interface to be simple and clear, as existing EPRs often were found to have poor usability. In the current way of working, many clinical data were not captured in detail or captured fully, and therefore mandatory completion of fields would be important. And also, as transplantation is a complex clinical domain, patients often have multiple medical and or surgical comorbidities. There is significant variation in patients' fitness and well-being. Therefore, the current model of capturing data included lots of potential data points. However, many of these would not be relevant for all patients. Therefore, being able to hide and minimize fields would improve the user experience. This image shows the first iteration of an initial user interface, which was shared with end users and formed the basis of an iterative process. Further, qualitative feedback highlighted how users did not see that any of the current systems were able to provide a transplant-specific patient summary. This meant that despite all data being electronic, there was not a single view that allowed them to, that complemented their workflow. Furthermore, it was important for users to be able to access relevant investigations and results within the same interface, and indeed within the same system, which currently was across disparate systems. We undertook a feedback survey following a live demonstration of 14 end users, which showed that all participants agreed with the phrase that a system like Kidney Cloud would be useful for them. This is an image of the user interface showing a transplant-specific summary screen. Discussion. Early prototyping and end-user engagement helped the project overall and drove buy-in from clinical stakeholders. Design and usability was found to be critical to digital health innovation. However, it has been frequently underreported. Hence, we felt it was important to share our findings. We believe that the methodology of iterative incremental user interface design with a clinical super user acting as a bridge between the clinical workflow and the design process was an effective way of achieving meaningful results. It also better informed the potential back-end capabilities required to provide functionalities such as auto-population that would support the workflow. To achieve a user interface as described in the Kidney Cloud project, interoperability would be an underpinning challenge. We are now further exploring how data strategies such as OpenAir or FHIR profiles can facilitate such a user interface that is able to surface and capture data across systems and organizations. Thank you very much.